Welcome, everybody. Nice to see so many of you here to this webinar on making small nonprofit neighborhood homes a reality in Ontario. At least that's certainly our hope. I'm John Lord, founder of Seniors for Social Action Ontario. I'm a writer and a researcher. My recent book, and I have to plug that, of course, called Aging and Elder Care, Time for Transformation. And I must just say, in writing that book, I really came to the conclusion that we know how to create community-based alternatives to long-term care institutions. And so I'm pretty excited to be part of this enterprise. I'm chair of the SSAO Small Neighbourhood Homes Group. And I'd just like to emphasize a couple of things about SSAO. One of our missions is to be advocates for a robust community-based care system for older adults who need support. We've emphasized many areas in our work over the last 5, almost 6 years, including natural occurring retirement communities, enhanced, expanded home care, including direct funding, hub and spoke models, lots of things. And this idea of small neighborhood homes is really just kind of one more piece in what you would say is building a comprehensive care system. As probably most of you know, unfortunately in Canada, we lag quite a bit behind other countries in terms of the way we're dealing with older adults. Small homes, for example, we've learned in our research from European countries and even the United States, which has developed quite a number of small homes. So I'd like to start by introducing the amazing team that worked on this report that hopefully all of you have seen, called Small Nonprofit Neighborhood Homes, the Need and the Potential in Ontario. Sherry Dupuis is Professor Emeritus and University Chair at the University of Waterloo and co-director of Partnerships in Dementia Care Alliance. Sherry, wave. Doug Cartan is a founding member of SSAO, a disability consultant, community development specialist, a trainer, and Doug has actually previously managed a unique and highly individualized human service. Glad to have you on board, Doug. Gail Parker will be joining us shortly, and David McAuley is a semi-retired architect, although you're pretty busy, David. His expertise is in collaborative design, which we find very exciting, and is a designer of many community homes, shelters, hospices, and co-housing. We're very pleased that our report, which I hope most all of you have seen, has been very well received by Ontario Health at Home, and also many communities. We've asked communities and nonprofits to step up if they're interested in designing and being part of a small home, and many of them have. We're very pleased about that. And we think we're on the way to making small homes a reality in Ontario. So today we'd like to highlight a couple of things about our report, but spend most of the time on what we're calling 11 criteria for effective implementation of small neighborhood homes. I would just maybe point out at this stage that if you have questions as we're going through the presentation, which won't be too long, please, you can put them in the chat, or at the end of our presentation, you can raise your hand. You go to the bottom of your screen and you can raise your hand that way as well. So let's start with a definition of a small neighborhood home. We've defined it as a home that provides safe, accessible, and supportive living to a small group of individuals or couples, maybe 3, 4, 5, 6 people living together, people who live with complex health conditions and related physical or cognitive disabilities requiring 24/7 care. It's important to emphasize that these are homes absent of institutional and clinical markers that you would find in most retirement homes and long-term care facilities. And the important thing also is that they're embedded in local communities. The other thing we emphasize in our report with this is value-based work. We know from research that when a human service has strong values and principles that guide implementation and development and ongoing operation, that those services provide better support and have better outcomes. So I won't go through all the values, but just emphasize some of them. This is non-for-profit work. We're going to build in collaborative decision-making all the way as we're developing the homes and in the co-design of the homes and decision-making in the homes. We expect these homes to be a good fit with the neighborhood, and we're really emphasizing accessibility both within the home and to the outdoors, because we know how important it is for adults, older adults, to be connected to nature. You know, when I was writing my recent book, I looked at about probably 15 or 16 long-term care facilities in Southern Ontario, and not one of them had easy access to nature. And yet we know how important it is to have access to nature on a regular basis. And the other value that's so important is relationship-centered work, and that these homes provide meaningful participation and a sense of purpose for individuals and for families. You know, it's really important to emphasize that these small homes we're talking about are not a smaller version of a long-term care institution. We're not just saying, here's a long-term care institution, let's make it smaller. We're talking about small neighborhood homes that are different in approach, different in values, different in scale, and different in philosophy. I think this is a really important and crucial point to remember as we go through some of the implementation ideas. And Sherry, I'd like to ask you, Sherry Dupuis, I'd like to ask you at this point maybe to build on that point in terms of, you know, what's the solid rationale for small neighborhood homes?
Well, thank you, John, and thank you everyone for joining us this afternoon. Research evidence is really very clear. Older adults don't want to spend the last years of their lives, and they don't want to die in long-term care institutions. As John mentioned, small neighborhood homes provide a viable and the preferred option for older adults. So why? Well, small homes are much more able to protect older adults and the people who support them. We saw this very clearly demonstrated during the pandemic, where over 80% of COVID-related deaths were associated with long-term care institutions. And this is compared to very few deaths that we saw in the small homes supporting people living with disabilities in the community. Small homes are more flexible and malleable and much more able to support older adults from diverse backgrounds. In fact, research has demonstrated over and over again how long-term care settings can be quite harmful for racialized and Indigenous older adults and older adults from the LGBTQ two-spirited plus communities, as well as other marginalized older adults. Small homes can support couples in aging together rather than being separated, which is the common practice within the long-term care sector. Small neighborhood home construction is simpler, faster, less costly, and familiar in most neighborhoods for many local building contractors, trades, and building supply providers who know common local practices, climatic idiosyncrasies, and permit approval processes. Most projects of this size can be completed within a year. Small homes for older adults in regular neighborhoods provide opportunities for continued community engagement, connections, and the maintenance of relationships with family and friends. And we know from research that these relationships are often fractured with the admission of a long-term care institution. Research also shows that staff in small homes provide more consistent and personalized care determined by the routine and rhythms of the residents, not the support staff in the long-term care system, such as providing meals or a shower at a time that suits the person. Finally, we know from research that staff turnover in small homes is far less than in the long-term care sector. So John, I'm going to turn it back over to you.
Thanks, Sherry. I think, and you think if we think of the values in the report and the rationale, these all create kind of like stakes in the ground as we think about moving forward with implementation. So at this point, we'd like to share the 11 criteria for implementation that we've developed. And we just want to say that the 11 criteria we think should apply to all homes. It's kind of like a universal set of criteria that should be everywhere. Now, this doesn't mean that there might be variation in the way homes are operated. For example, in terms of food or schedules, depending on the people who are there, depending on the culture of the residents. But we think these criteria are pretty solid in terms of their need for everybody. So criteria number 1, government funds both operation of the homes and capital costs to build or renovate an existing home. So this is really important, right? The government funding is going to be twofold, right? Obviously, operation is the services that are provided, the supports that are provided, and there's going to be capital costs, obviously, in terms of either renovating an existing home, which may be difficult, or building a purpose home in land that's provided in the community. Criteria number 2. Non-for-profit, not-for-profit community rate the homes, recognizing that it could be 2 organizations. Could be one for housing and one for the housing component is different, is delinked from support, but it could be either way. It could be one organization. Doug, do you want to add anything to this important criteria?
Yeah, I'll say a few things, John, about this. We are very supportive of this being a initiative by the not-for-profit sector. And there's a few reasons for trying to focus on that. Long-term care right now is dominated by the for-profit sector, and we think there needs to be more choice as this system matures and expands to serve the cohort that's aging right now. And the nonprofit sector is a really important sector to invest in for the expansion of elder care. And a couple of other reasons sort of point that out. One is there's just a greater amount of accountability to local citizens when you have nonprofit organizations embedded in community with local citizens on local boards running local services for local people. And we see that also with municipalities, and we see it with nonprofit organizations. So we think there's enhanced accountability in this model. Secondly, I think there's something to be said about how communities rally around and support nonprofit organizations in your community. The ability to raise funds, the ability to offer people's time to nonprofit organizations, volunteerism. Thirdly, I think it's important to recognize that nonprofit sector is not embedded in this conflict of interest between rewarding investors with money for investment and this idea of profit in social services in favor of using all of the money, including fundraise money, and even more than that, to invest directly in the services and programs. So there isn't money leaving the organization. It's all going into the services and programs of the organizations. And finally, I want to just highlight expand on one point that Sherry touched on. And that point was the idea of being safer in nonprofit organizations. And we come back to the story of what happened to people during COVID. And we know that the for-profit sector had the greatest number of deaths during COVID in the long-term care industry compared with municipalities and nonprofit organizations. And just to give a very, very specific illustration to Sherry's point, we know there were about 78,000 people living in long-term care when COVID broke out, and they had over 500 deaths per 10,000 people due to COVID. In the small home nonprofit sector in Ontario for people with disabilities, there were 26 deaths per 10,000 people. 26 deaths versus over 500 deaths is 20 times the rate. And I think we should keep that in mind when we think about the need to invest and build up the nonprofit sector.
Thanks, Doug. That's a very powerful rationale for the not-for-profit community organizations taking the lead in implementing small neighborhood homes. Criteria number 3, and I'll just say that we will be mailing out the criteria when we send some information to you tomorrow, including the recording, or in the next couple of days. Criteria number 3 is about municipalities. You've all already touched on this a little bit, Doug, but our criteria says municipalities, if possible, partner with non-for-profits by providing land. In some cases, they provide land where housing can be built, infrastructure support, and approvals. Oftentimes, municipalities have to approve buildings. Engagement in municipalities will also provide strong support for the idea of strong neighborhood homes. And that was the point that Doug was making. And we really see the nonprofit entities collaborating with the municipality to provide momentum for this to move ahead. Anything else to add to that, Doug?
Yeah, I want to make one more point on that, John, why we're thinking that municipalities are a strategic partner in this initiative. Municipalities right now invest in the own long-term care homes that they operate. They provide local tax dollars to help with the operation, and that's why there's sometimes greater staffing levels in municipal homes. Right now, I can say to people that municipalities have the choice of how to invest in these various social service programs that they're offering. Right now, for example, I'm a taxpayer in the counties of Leeds and Grenville in Eastern Ontario, and my county government is taxing the local citizens for their funding portion of the new long-term care builds in my community. There is no reason that long-term care couldn't also use money to fund what citizens are asking for, which is to age at home in their communities. And so we think there's a strategic partnership with municipalities that can bear lots of fruit if they're willing, as they are right now, to tax citizens to build the long-term care home, which lots of citizens are saying they would like to have a choice in how they age.
Yes, and we're already finding, Doug, we're already finding in terms of when we send out a note asking people, are they interested in helping make a small home a reality in their community? We're already finding some communities and service providers are developing those strategic alliances in Ontario. So that's very encouraging. Criteria number 4, small homes in existing neighborhoods are a good fit with that neighborhood, are close to local amenities, if possible, of course, and provide access to outdoors and nature. And David, I think you have a couple of slides to show people here.
Yes, thank you, John. I have some slides and some comments and on criteria. Basically, I want to talk about desirable locations, include accessible walking trails, parks, playgrounds, public transit, certainly medical care, healthcare facilities, pharmacies, senior centers, entertainment, coffee shops, places of worship, and shopping. So those are some of the things that that should be considered. But the criteria for sites should be documented with professional feasibility study first, and then locations should be vetted by the Seniors for Social Action Ontario resource group, so that we see that the success of the location is assured, as well as the care, of course. That's all I have to say there, John.
And the slides are coming with the next one?
Yeah, hopefully.
Okay.
We can go to back to the first slide if we can get it up there.
So criteria number 5, which David's going to build on, small homes are deeply connected with community resources, and he talked about some of those resources, ensuring that residents have easy access to not only public resources, but also medical specialists and older adult services, as well as generic community resources such as public libraries and other resources in the community. Back to you, David.
Yeah, it's certainly important that the design fits into the streetscape and blends in with the neighboring homes, and our small scale has been mentioned before. We want residential windows and dormers and porches, sitting areas, generous landscaping. So this map just basically shows the location in the cities, and I've talked already about some of the amenities that should be nearby or certainly within walking distance. So the site is quite important. So we can skip to slide number 2 now. That's where we talk about the streetscape blending in with the neighborhood homes. So it's very residential looking and certainly incorporates landscaping and intensive natural landscaping in the features here. And as you can see with this particular one, there's a porch involved there where residents can sit in the shade and protected areas and still be outdoors. You can go to slide number 3. Certainly in the entrance area, natural elements such as in this particular case, a living wall welcomes the visitors and friends and families and encourages gathering and camaraderie amongst the residents. So there's certainly noise reduction and visual cues to be addressed with environmental awareness for resident conditions such as dementia awareness and mobility needs, where the environment is very important to their well-being. Slide number 4. Certainly the common areas would include a kitchen, living room, lounge, quiet room, library, laundry, any of the rooms that are in anybody's house, basically. And also providing things like walking loops so people can walk around in areas without having to go up and down halls and have dead ends and that type of thing. It's careful consideration of sunlight and abundant windows on all sides to provide warm, sunny places at all times of the day. Next slide. So the rooms themselves are bright with bay windows and plants, and certainly people put their own personal aids in the area that call home to them. Certainly medical aids and equipment are inconspicuous. So in this particular room, they are there, but it's more in a residential access here. Certainly access to outdoor decks is encouraged and people are allowed to be there. Residents are encouraged to bring personal items, artwork, furniture, memorabilia to make their home familiar and comfortable for themselves individually. Next slide. So as an architect, I'm kind of part of the nuts and bolts of short small care homes. And so we want to talk about that. So we've developed, because of the priority for safety, accessibility, security, maintenance, and operating, we feel that new construction on one floor is less costly and more practical than renovation and addition for the homes. We say, certainly for safety, we say that small care homes should be sprinklered and with fire separations and exceeding minimum building codes. Buildings are environmentally sustainable, using healthy materials and finishes, low energy, using green building technology, passive building criteria, and very well insulated and draft-free for the comfort of the residents. Heating and ventilation systems will be individually contained and controlled for personal preferences and infection control to mitigate the possibility of spreading those, as is mentioned before. Consideration should be given for climate change, certainly power outages and extreme heat and weather events that are part of climate change that we're seeing everywhere. Small care homes should be designed and customized to suit the local requirements, as Sherry has mentioned before, and location, but there are advantages to using proven designs and prefabricated construction, so that certainly has to be considered in the total package. So in conclusion, to be successful, the development process, design criteria, and standards for small care homes should be drafted in consultation with the SSAO resource group, and we can put our expertise together, put our heads together, and come up with something. And as been mentioned before, it's not a matter of downscaling or tweaking long-term care design guidelines. That's all I have, John, for now.
Okay, thanks very much, David. That's really gives people a good idea of what a home might look like. And I love that diagram with, 4 bedrooms, 4 bathrooms, a large common area where people can actually maybe even be part of the cooking or be part of the kitchen, a genuine home. Gail Parker, are you here? Gail is the 5th member of our team, and she doesn't seem to be here right now. So let me go to criteria number 6. Small neighborhood homes support 4 to 6 adults who require intensive care with a focus on support needs, not diagnosis. And that's an important point that we're making and probably would need some discussion with the total group later. But it's kind of moving away from this idea of we're not interested in creating a home for people with dementia, but we're creating a home where people with a diverse number of needs can be together in a way that makes sense. Criteria number 7. Residents in a small home come from the neighborhood, if possible, and are carefully matched with fellow residents and can include couples, not just individuals. And Sherry already mentioned that, but I think it's a really important point. We're trying to create a home, and if possible, people from the neighborhood are living in the home. And so people may actually know each other, or there may be a process. There'll be a process where people can be together in that home and get to know each other well, even before people move in. Criteria number 8. All small homes are grounded in the key values and principles that we talked about. And these principles and values guide the day-to-day operation of the home. And here's the point, really, to ensure that the home is as free as possible from institutional markers and provides choice and relationship-centered care. And that's kind of unique, I think, to the small homes that we're proposing. And Sherry, perhaps you could add some comments to this one, could you?
Yeah, so much of the long-term care sector has been grounded in what we call a medical model with a lot of focus on illness and diagnosis. And the response to that, after many criticisms, both from researchers and professionals, to that medical approach was what was called a person-centered care. However, researchers and professionals around the world have argued that person-centered care, which sees people as people first and not their diagnosis, is important, but it's only a starting point. And so there's been a lot of argument for relational centered care, or how I refer to it as relational caring. And the difference is that care is always embedded in relationships. And so for good care to happen, everyone in the relationship, everyone in the care context has to have their needs met. And so when we're talking about the care of older adults, we have the older adults themselves, but we also have family members around them. And we also have support people, we have friends, and all of those people need to be thought about in terms of what's best for the care of older adults. So the way this might look different in small homes is that instead of what we often see in long-term care or retirement homes is the feeding of older adults, in small homes, as we would in any family home, everyone would eat meals together. And so we would have families invited, support staff would eat with the older adults living in the homes, and people within in the home. Often we see, for example, hired recreation staff would provide activities just for the residents. Well, relationships take time to build. And so we believe strongly that activities need to be for everybody in the household. And so that includes family, that includes support staff, that includes residents who live there. So it's thinking very differently about the way we treat what's happening in these homes than we would in the long-term care sector, and always recognizing that older adults, particularly older adults with dementia, who are often denied this, always have relational capacity. They always have the ability to engage relationally with other people around them. So I could talk about this forever, but John, given time, I think I'll stop there.
Well, thanks, Sherry. That's a very powerful idea. And it reminds me of what the green homes in the United States developed. And this is called the kind of the universal worker. And so, you know, as a worker, I might have helped somebody have a shower half an hour ago, and now I'm having a tea and a muffin with another resident in the kitchen. And maybe in 20 minutes, I'm supporting somebody to do their exercises that physiotherapy recommended. So this idea of relationship care is so central to the idea that we're proposing. Criteria number 9. And this is a new one for some of you possibly, but because we didn't have it in our report, but this is about in-depth staff training. And really, it's not just staff training, it's training is provided for staff, volunteers, and for families as well on the key values and principles, including the relationship care philosophy that Sherry just talked about. We think that training is critical prior to the opening of the homes and ongoing once the homes are operational. And between the 5 of us, we have a lot of experience in training. I don't know whether anybody, perhaps you, Sherry, again, do you have a quick comment on this?
All I can say is that I've been working my entire career on culture change, and the medical model is just so dominant. It's so out there that it's very easy for people to fall back into that, into those practices. And so without without understanding first the philosophy of small homes and relational caring, and then continually engaging with those ideas and learning and sharing together, it's very easy to get caught up in the dominant culture that's out there. And so, so culture change doesn't happen unless we actually create these cultures of learning as well within those environments.
I love that phrase, culture of learning. We want to hope that all the homes have that culture of learning built in right from the beginning, and even before the beginning, right? When you're starting to think about it, even right now. Criteria number 10. Older adults have a vital role to play in the home, either as residents or as family members and friends, ensuring that policies and principles and input from older adults on a regular basis. Older adults and family members are also included in the co-design and decision-making in the home. And any of you who know my work over the years will know how passionate I feel about that. And we know that we get better results when the people who are supported and the people who love the people who are supported are engaged in the process. Criteria number 11. We're almost finished, folks. We want to open it up for your questions and comments. But criteria number 11 may be the most important. They're all important, but this is kind of an oversight role. We believe that a provincial resource group will be needed, kind of an oversight group. A provincial resource group will be needed to provide training that Sherry talked about, and also to provide research on the small homes. Training will be offered to nonprofit providers and communities, and the research will be done by independent researchers, but will focus on small homes and implementation to ensure that the learnings are identified for future development. So just imagine that we have 3 or 4 homes, 5 homes off the ground in the next year or 2. We have a research component, and that research gives us insight into what's working well, what needs maybe changing a little bit. So we've got the ongoing staff training, and we've got the research. So it's creating that learning culture that Sherry talked about. And we think that both of those are really important for future development to really make these small neighborhood homes a reality in Ontario. So let's open it up for questions and comments.
Can I ask?
David, there's a question for you about the design. I think I mentioned 4 bedrooms in your design, but I think people are pointing out there was actually 5 bedrooms. So how big would the lot need to be for a house of that size? I guess that's really the question. And does this give you real choice in a neighborhood? If the lot has to be too big, can you really have choice?
Yeah, thanks for the question, and John and everybody else. Martin actually has answered that question in the chat, and Martin's the architect that worked with me on this. And the lot is 60 feet by 120 feet, which is a fairly typical residential lot in municipalities. Maybe not the downtown older areas, but certainly in the underlying ring of access. So, that's about the size. As far as the number of rooms are concerned, the particular plan we have can be either reduced or expanded. As you can see, the bedrooms are all on one side, so for a longer lot, they can be adjusted. This was done, without a lot of information, but this is one of the ideas that we had. So, the kitchen and living room can also be extended independently of the rooms. So this design can work from a number
So
of
you
points
think,
of view.
David, it wouldn't be too difficult to find lots that size
I'm
in
thinking
urban?
maybe a larger lot, but I mean, if it's small lots in the right location, I would say maybe two lots have to be annexed together, or greenfield can happen. But there's a lot of underutilized lots in the city as well, and
Yeah.
I think, as I mentioned in my talk, we're looking at the possibility of additions to homes as well, and renovations, but that makes it very difficult as far as accessibility is concerned, and very expensive to put in things like elevators and ramps.
So thanks, David. There's 2 or 3 questions about funding, so let me go to those. So the question is, I'm curious to know if any locations have been identified for piloting this. No, we're really in the process now of communities and nonprofits coming out of the woodwork and saying to Ontario Health officials are having conversations with different communities. And yes, we have some municipalities have indicated a desire to be involved. We've got 3 or 4 communities that have stepped up and shown an interest. So there's not funding available at this moment, but we're hoping that funding will be available in the near future.
John, can I jump in just quickly on that?
Yes, this is Trish, who is the chair of SSAO.
Yes, with the help of this group, we've been able to put quite a bit of pressure on Ontario Health. And Ontario Health undertook to actually create small homes in Ontario. They're quite keen to get this going. They've already interviewed some people in municipalities and nonprofits. These are names we've given them. And so they're just going through the process with their own leads now, and then they're going to, I believe, identify the communities that they want to get startup in. And as soon as that happens, that's when the funding negotiations will occur. So it shouldn't be too long, just to give everybody some hope.
Okay, thanks. Are there any hands up in the anybody want to ask a question directly?
I think Leslie had her hand up, and then Peter, and I think Marilyn's got another question in chat, John.
Oh, yes, I see that. But let's go to Leslie first, then we'll go back to the chat in a minute.
Yeah, my question was also about, is there anywhere in Ontario that is already can serve as a model? And is it possible to know which municipalities have been interested in this? Trish, could you answer that?
Yep, I can. Halton Region is talking to Ontario Health right now. People up in York Region are also talking with Ontario Health, and in Durham Region.
Thank you.
There are several other communities that have shown interest, but I won't speak on their behalf. But I think they'll be making some public declarations soon. There's a question: how many staff members might be required to operate such a small home? I think we had something in our report about that. Does anybody remember what our response was to that?
I don't think it's not many, John. Of course, it would depend on the size. We want these to stay small family units. And so with one support staff that could provide support during the day and another at night. John talked about how the greenhouse model in the US uses multi-skilled staff. So we don't have these staff silos where you have people who clean, people who cook, people who do rec. In these homes, the staff would be multi-skilled, so they'd be able to do a number of those of things. But yeah, John, I'd have to check the report to see how many we had thought.
Well, I actually think we talked about, I just checked it now. I think we talked about there'd be 2 staff people during the day. So for 15 hours during the day, there'd be 2 staff people on, and there'd be 1 person overnight. And there might be one more person who might be, in charge of the food, for example. I mean, the ordering and all of that kind of thing. But Doug, perhaps you want to add something.
Well, yeah, just to that point of the question, the ministry, Ontario Health, asked us a similar question about this in a way. And we said to them, well, yes, in our proposal, we had a couple of staff identified and overnight support because people would need that. We also had staffing that may come and go. You don't, I mean, even though it's called a nursing home, there isn't an abundance of nursing in nursing homes. If anybody's probably seen that. So yes, but some people do need nursing from time to time. Some people do need a doctor from time to time, but it's not dominated by that kind of skill. It's there. And so the staffing needs to be able to rise and fall as the needs of the people who live there dictate. So one of the things that we were very adamant about with Ontario Health was this needs to be a people's home. So you don't get passed along every time your needs change to another physical place. It isn't from small home to big home to long-term care to whatever. This is somebody's home, and we're really interested in if we commit to that principle, then as people's needs change, and if you're older and moving towards the end of life, your needs will change, and you might need some more assistance or different assistance. Maybe there's palliative care that's needed, for some people. So staffing needs to have a flexibility built into it, as well as having the ability to bring in specialists as and when needed. If it's around dementia or palliative care or somebody's medically compromised, then we have those specialists that come in. So this is your home. This is where you live for as long as you want, and the staffing can be flexible.
And John, if I can just point out, Peter has had his hand up. Marilyn has a question, and
Yes, I've got a list. I've got a list here. Trish, go over to you, Peter. Peter Clutterbuck. Was it Peter Clutterbuck?
yes, it was.
Looks like he might have left.
Okay,
Marilyn
then I think
Moulton.
Marilyn Dolmage, I think.
Marilyn Dolmage, sorry. You have a question, Marilyn?
Yes, I just put it in the chat just to follow up to the question about the size of the lot. I think it would be really important for a lot of us, myself included, to have the flexibility to live in a downtown location. So, we know institutions are often out of the center of towns, and to me, the thought of living in a suburban location isn't that appealing.
Well, I think that, thanks, Marilyn. That relates to a question that Nancy Orr asks in the chat. To ensure effective use of land use and to help with affordability, could there be multi-story design, even if it were to enable mixed use or multi-generational use? I think that's a great question, Nancy. Thank you. David, maybe over to you on that, because you've built those kind of places.
Yes, actually, we did a plan for a smaller lot in a more downtown area, and because of the amount of time we had, we didn't bring that forward. But yes, it would probably be a custom design with the same principles we talked about. Certainly, we would want to make it accessible, so an elevator would be important, but that alone is probably $150,000. So it makes a second floor level, third floor level pretty costly in terms of that. And then you certainly have the installation of sprinklers and fire separations and that type of thing as well. But the location is really important. It's like they say the fast food chain, it's always about location, location, location. And I agree with that. The location is vitally important. So the right building in the wrong place is not going to be successful. So I hear you on that, and I'm happy to share those plans. But again, it's the custom design, and those things would have to be considered. So I think once we have the design criteria and guidelines worked out, we can put that out to the community. The other one thing I want to just slip in as far as the design is concerned, I know Sherry talked about training. I think vitally it's important to have the designers trained as well. So we do have a number of people experienced in doing this type of building in group homes and medical facilities and that type of thing. But I think the training in terms of small care homes is a little bit different avenue, and I think that should be brought forward and maybe introduced through the universities and design schools. And so this can bring some really great ideas forward.
Well, that's
John,
an
I
important point, David, because it actually could be actually working with some designers and architects around the province as we get this off the ground.
Mm-hmm.
John,
Absolutely.
just to let you know, Peter's back.
Sorry, it's Marilyn again. I just really liked the add-on to my question, and that was the suggestion about multi-generational residences, or, not just all seniors in one place. Has that been considered?
Well, that's been a favorite topic of mine over the last few years, and I think it's very important to kind of bring that into the mix, right, and make that a possibility as people look at homes, especially in urban areas where there's going to be a lot of different possibilities of making. There's actually a group in Ottawa right now that's designing a multi-generational home that would have seniors and students, and so I think those kind of things are certainly getting more and more play around the country.
I think this is really important because we see young people really struggling with costs of housing. And as John mentioned, there's a number of municipalities now and universities partnering with homes so that young people can support older adults in their own homes, but also young people can have housing at a more affordable rate. And research on these initiatives it's preliminary, but it's certainly really positive in terms of both older adults and young people really gaining so many things from these arrangements.
Yeah. Thanks, Sherry. Peter Clutterbuck, I think you're back. You have a question or a comment?
One of our members, Cecilia from Oakwood Bond, has a question.
Yes, please. Hello, everyone. I would like you to explain the medical model. I heard mention of it. I reached late. I don't know if you had explained it in details. Yeah, but what's the medical model as it relates to old homes for older persons?
So maybe I'll ask Sherry to describe the difference between the medical model and a social community, a relationship-based model.
So when many decades ago, when long-term care, what were then called nursing homes, were first developed, what we saw was the medicalization of aging. And what that meant is that any type of illness or diagnosis or frailty associated with aging, which is a normal part of everyone's life, was medicalized. It became all about anything that happens throughout the life course is associated with illness, a diagnosis, and then needing medical and clinical treatments. And so the ways that we often saw in the early nursing home movement was, for example, seeing it, it wasn't uncommon to see nursing stations as soon as you came off or into a floor off an elevator, there would be a nursing station there because the primary focus was on diagnosis and illness. A community relational model doesn't start with the diagnosis. It starts with people and relationships. And so, of course, as human beings, we all have the possibility of getting ill or having some type of frailty over the course of our lives. That is just a part of being humans, but it doesn't define us as we get older and as we become older adults. And so the focus has to be on people as relational beings and in relationship with others, and not only on our diagnosis. And so as Doug was saying, what that means is that of course people are going to need nursing support. They're going to need palliative care at some point. They might need different types of specialists. But those are people that we would all go out and get that support or have that support come into our homes. My father was quite ill for 5 years and received palliative care in his home, and had a number of health issues, but his diagnosis wasn't the focus of his life. So I'm not sure if I'm explaining it, but I think the problem was in the beginning, aging was defined as a medical problem. And so diagnosis and illness was prioritized as opposed to people and relationships. Does that make sense?
One more question here from Judy.
Yeah, hello. I'll try and make this as quick as I can. I'm talking from an urban setting in Toronto, and I'm just wondering, it seems like what I'm hearing is that there's a move to provide resources for planning new small homes. I'm wondering, will there be resources for taking existing facilities and adapting them to not fit exactly what you're describing, David, but something very close to? So are there any resources that we can use to adapt an existing facility?
If I can take that question, John, I would say that what we're looking at is the principles and the criteria, the design criteria that we're looking for. How they're put into built form is something else that would have to give some consideration to the existing building and the property. So you can't do a model for that because there's so many different types of older buildings, let's say, and key locations. But I guess it's the intention is there, the design intentions and the basic program, the design program is still the same. So of course there are building code issues and municipal bylaws and things like that that have to come into play as well. So there will be differences in every home, actually, with all the municipalities that we have and all the different zoning bylaws and official plans and that type of thing. So it's pretty hard to get those standards together. And I guess if your question is what standards do we have now? I don't know that there are any standards. There's a draft in Alberta, I think, that's out there. There are some issues with that I can see, and I think it's a draft that's out there. So that's maybe a starting point, and maybe we can work together with other municipal or other jurisdictions, let's say, that have worked out design criteria and build on that and adapt it to an Ontario location for that.
Thanks, David. That's very helpful. Any other comments, Peter, up your way?
Got one more here, if you don't mind.
Okay.
Hi, my name is Gila, and following up on Judy's question, what would happen if in an urban area where there are many facilities nearby, like what if I wanted to take my home and make it into a let's have more people living in it, elder people, and I wanted to have renovations happening on the whole property? Would I have any support from the government to do that kind of thing, following the values and the of the homes we're talking about?
Any thoughts, anybody?
Yeah, I'll say a couple words about that. So this is pretty new, right? In terms of the Ontario Health, and what we're trying to introduce is an idea that says, and now I also want to say that Seniors for Social Action Ontario has been advocating for a range of alternatives to institutional care, which includes really enhanced assisted living programs, really enhanced home care, so that people don't just, have to argue to get 1 hour a week of support. We want a much more robust home and community care system that can allow people to age at home really long, for as long as they can. There are some people, however, we believe that regardless of how much home care is going to be provided, it will be very, very difficult to remain at home. And you can think of, I'm sure, some examples in your own community. And for that, we're introducing the idea of small homes. So and we're talking to the government about that. It may come to pass that people have more unique ideas that can be put forward to the government that can also try and change this model a bit, like you're talking about homes that can be renovated or refit. And I think that's an interesting idea that can be put forward right now. So this is very new. So we don't have all the answers about what the government will fund or not fund, but they've shown a real interest in funding smaller homes as an alternative. And we think that's an important door that's opening that we can take advantage of. So if people have different ideas, we're talking about nonprofit. I mean, people might be talking about renovating their own homes and getting grants for that and sharing it with another couple of people. That's a different model still. These are all good ideas. So I would encourage organizations that are together, seniors organizations, maybe like your own, to put more ideas on the table. I think that's a very good idea.
Yeah, very, very healthy to see people thinking outside the box in a way, right? Being creative in their own communities. And that brings me to the next question from the chat from Andy Swain, who asks, what consideration has been given to implementing this model in rural, smaller communities? And has there been any discussion with existing non-for-profit community living organizations as partners? So let me say a couple of quick things before I open it up for other comments. First of all, any organization that's a non-for-profit is eligible to kind of make their interests known to SSAO. That's the first thing. And the second thing is that for those of you who don't know, community living organizations there's hundreds of them in the province, I think, that provide supports for people with developmental disabilities. So they have a long experience, and some of them are doing very well in terms of providing small homes for people with disabilities. And Doug, that's been your area of expertise for some time. Do you want to add anything to that?
Yeah, I'll add to Andy's comment here. As I said before, this is new, and the partnerships that we're talking about are quite new. Trish mentioned a few of them. So this past week, I met with a local community living association in conjunction with Habitat for Humanity. Habitat for Humanity was very interested in the idea of building homes new and differently, and with support in those homes if it could be provided by another organization. So here we are looking at another way of doing this, another partnership that might be out there. And frankly, I was a little surprised of the openness that Habitat for Humanity was showing in the work that they do. They had just built some townhouses where 2 of the units were fully accessible and are now being used by people with disabilities, and support coming from outside of Habitat for Humanity, of course, because they're the house builder. So I guess what we're also saying is, we're putting forth some ideas about partnerships with municipalities, etc. But people are writing us when we put out this report, as Seniors for Social Action put out the report. It's not, the response is unlimited. People are coming in with all kinds of ideas that we hadn't initially thought about. And I find this very creative to think of organizations doing something different than they otherwise might have done, or ideas like questions coming from the group in Toronto there about other ideas. So I think lots of things are open right now.
And Doug, that's a great example. Your Habitat for Humanity example is a great example of delinking housing and support. So you have a housing provider and then another provider that provides the support. And in some ways, that's a very unique kind of partnership. But I appreciate your emphasis on we're learning together, right? And we want to learn with all of you and communities that are in touch with us. It's been very helpful. Are there other hands up? Anybody else have a comment or a question?
Stacy Landau has her hand up.
Hello, Tracy.
Hi there, everyone. So first of all, I just want to congratulate you all. This is amazing. This is very exciting work. I was really excited when Trish reached out to me. I do have a meeting set up with Ontario Health at Home next week, I think it is, to talk about expansion or just bringing this idea to North Toronto. And I did want to let folks know that we actually do have a very, very similar model in play. I don't know if folks know about it in North Toronto. It's called Ewart Angus Homes. It is within a building. So it's
Could you just say that again? What's the name of it?
Ewart Angus Homes. I'm with, and sorry, I should have introduced myself. I am the CEO of its Sprint Senior Care. We used to be known back in the day as Senior People's Resources in North Toronto, but that was a long name. And I worked with Jane Moore until her retirement and now continued on her legacy for those who know her. And in 1999, we collaborated with the Alzheimer's Society and a gentleman named Ewart Angus, who has now passed, and he had a vision similar to your vision. And he donated a lot of money for the land. And there is a 6-story building on where our head office is on Merton Street. 4 stories are for regular everyday people, to rental units, and 2 stories were purposely built as per almost identical to your description, for senior people who have dementia, who weren't able to safely live at home, but absolutely did not need to be institutionalized. And it is a non-medical model that we have PSWs or recreational therapists who just simply do queuing. It is 20 residents. There are 2 floors with 4 pods, no dead ends, walking as they see fit. So it's secure because of exit-seeking behaviors, but they, we wanted to make it as home-like as possible. So, for example, each pod has their own kitchen, their own den, their own piano. Like, they have their own bedrooms with their own shower, their own washroom. There's no scheduled time for eating or activities. Or there are, but they have the freedom to do as they see wish. We have walking programs. We have a gardening program. We have, so it's art-based, and families can come and go as they see fit. There are no visiting hours. It's very, very close to what you describe. And it's been running really since 1999. So I have been working with others since then to say, you need to replicate this model and do things like the small homes. So where I'm going with that is I want to let you know and give you hope that this can be done. It is being done in some ways. I think replicating this with the flexibility of whether it be a physical, like a traditional home or a semi-detached or an apartment, it can be done in any way if it's done with thought and consideration and the right partners. And I would be I'd be pleased to talk to you folks offline if you're interested. And I can give you a tour of the site if you're interested, if that's helpful. But where it comes into play, we are not for profit. We are funded primarily through Ontario Health or Ministry of Health. But it is the intricacies that maybe I can bring to this now that I understand more. I'm kind of glad I had this before in my meeting with Anna Greenberg, is to bring her the potential of what Ontario Health and the ministry can do with funding models. Because I think that's what they need to do. They're big bureaucracy, and they need to figure out how to bake this into their current models. And I would say assisted living is the way to go. That's how we got this funding. I don't know how. It was under George Smitherman days. There was a small pocket of time they opened it up and we got access, but it's closed and no one's ever had access since. And they're sitting on a little bit of a gold mine here, and they could easily, I think, open this up to a few providers that have been doing similar programs. And we could take the principles of your program and run that. And the key thing is getting the challenge now in Toronto is getting that land and a partner who's willing to give the space. But it's doable. And I think that this is.
Thank you very much for sharing. That's very exciting to hear about. And I think there are a couple of other projects in Ontario that have also developed small homes, and some of those we described in our report. I'm sorry we didn't put yours in the report, but we could have. But that's good to know. Thanks so much. I'm sure we'll be in touch then.
John, and now you know why we referred Ontario Health to Stacy, because they have had that experience for years.
There's a question about zoning, David, and I wonder if you could pick up on that. Do you expect there might be zoning issues in terms of implementing a home in smaller or medium-sized communities?
Yes, I would say almost without exception, the zoning has to be changed because the zoning bylaws and official plans are, I would say, archaic, and that's admitted by a number of planners. They really don't plan ahead. They basically plan in reaction to public input and that type of thing. So I think that's one thing I would ask everybody to do, to talk to your municipal councillors particularly, and staff, and get them to zone some of these properties that allow things like lodging houses or group homes. As of right, I think that would be the answer to a lot of the shortage of affordable housing as well. Because we have a lot of people who can't afford homes, obviously, of their own, but with a group they could, and they could share the facilities, whether it's women living with women sort of thing, and Abbeyfield homes, a lot of different models that are out there, and the cost and the length of time it takes to go through zone changes and all the municipal requirements it takes to do that are really onerous and costly and time consuming. It doesn't need to be that way when they can zone the properties to allow for this type of use. I mean, five rooms is not unusual, but you could have a family of 10, 12 children living in the same house, and that's no problem.
So David, this is a great example of the importance of having a municipal partnership, right? Because if you have the
Absolutely.
municipality and the mayor on board, you're likely to be able to deal with those zoning issues in a productive way.
Yeah, I hesitate to say strong mayor powers might permit some of this as well, at least facilitate part of it.
Any other questions or comments from the participants? Thank you so much, everybody, for being with us today. This helps us, your comments, your questions.
I
There's
think
Steve.
he just put his hand up.
Hi, how are you? Sorry I was late getting in. Computer doesn't do the things that I want it to do anymore. Anyway, I got in late, but you had the designs that were up. And it was interesting as I started looking at them. I live in Perth, Ontario, Perth, over by Ottawa, but an hour away from Ottawa. And we have a nonprofit community group homes for adults with developmental disabilities. And we've had them. I was looking at your model, and it almost looked like 2 or 3 of the homes we already have. Most of these homes were funded originally as people were, the government were reducing the numbers of people at Rita Regional or some of the other area facilities, and they're trying to bring people back into their home community with family and all that sort of thing. So we have 5, I guess, homes in Perth, and Perth has 6,000 people. So it's not very big. That's why I call it we. And when we are doing that, I remember when we started, we were having problems with communities and, NIMBY, all that kind of stuff. I had death threats at one point, believe it or not. But now, we've built several homes. We haven't done the last one, and our last one was quite a while ago, even now, because we just can't get funding. And but I just sort of see how they now they fit into the community. Nobody mentions anything about them. They're all, very, are doing things that they want to do. And they just fit right in. You wouldn't, I drove you down most of those streets. I don't think you knew that they were group homes. So, and they would hold, we were forced to move ours to 6 people for financial reasons, I guess it was. We were trying for 4, but the idealism died. So that's where we're at. But I just wanted to mention that because in our little town, I'm trying to get our nonprofit organization interested in doing something like this. There are people involved, but I don't know whether or not my organization will agree to do that anymore. Most of them are pretty burned out. So we'll
Steve,
see.
if I can just interject, Tay Valley has been in touch. They will be talking to Ontario Health, and they're in your area.
Good. Yep. They're just down the road.
Okay, thanks, Steve, for sharing that. And I think your point really is that over time, communities accept the idea of small homes, right? They become part of the fabric of a community over time.
Yeah.
Marilyn Dolmich, your hand is, did you have another question?
Yes, and it happens to be a really good follow-up from the last one. I really agree about the importance of the 11 criteria, but I think it's really hard to make sure they're happening. And I think, John, of your book from, I think, 1986, when institutions were closing in British Columbia. And I was involved with closing an institution, which happened by 1993. And we had great hopes that group homes for people with developmental disabilities would be a stepping stone to real community involvement. And I really have to say, with my knowledge of the province, that has not happened. I'm glad it seems to be happening in Perth. People are comfortable, but that doesn't mean really valued lives. That may not be the experience that an individual in a group home actually has, where, for example, it's quite common to talk about an outing to the community as a walk down the street where you live. So the ideals we had about group homes for people with developmental disabilities have been hard to maintain. And I know that this is just one of the many options we're hoping to have available for people, and appreciate that. But one of the, I think one of the parameters around this, someone earlier talked about a whole lot of different programs available for people. And I think that program thinking is really problematic, that you really, when you're trying to think about individuals, you try not to think about groups of individuals all doing the same thing, that program should not mean that. Programming is different. But also the question has arisen around rental versus ownership. And I can see that rental is really, would be hard to work with this kind of model. But I think that there are group homes that exist in Ontario that maybe shouldn't still exist, except that they were purchased and there was money to buy and build a residence. And that eliminated some choice that people had in terms of individual choice and in terms of the kinds of non-program thinking that agencies might have done if they hadn't owned the building. And I know that Nova Scotia is entertaining this right now in thinking about trying to find more accessible rental accommodation. So
Marilyn,
lots of issues.
You keep cutting in and out.
Oh, I'm sorry.
That's okay. I know, I think your point is very well taken. And I know that some of us on this experience, as you pointed out, I've since middle of 1980s. The group home model in the developmental disability world has not worked very well for a lot of people. Many of them have become very institutionalized. And so we're very conscious of that. We're very aware of that, which is why we wanted to start by thinking about criteria, number one. And then number two, we wanted to think about what would help keep those markers going. What would help keep a home on track with the values and the relationship-based care that Sherry talked about? What would help? Certainly training would help. Certainly research that is learning-based would help. Certainly family involvement and older adults involvement would help. But maybe I'll just add one more thing, and then maybe Doug or others want to add. We're really talking about creating some quality of life for people in the last 2 or 3 years of their life. People in long-term care only live there for about 2 years on average. So we're trying to improve the quality of life for people at the end of their life. Not necessarily improve their quality of life, but help them keep a quality of life. And I think that's very different than putting a 21-year-old in a group home and saying, this is going to be your home for the next 60 years. So I'm not excusing that, but I just think that we're in for a short run with people. And I think it's going to take a lot of work and a lot of criticisms from people like Marilyn and others to keep us on track, right? That's going to be important for Ontario Health at Home to stay on track and for all of the homes to stay on track. Doug, thoughts as you hear this?
Yeah, I think it's a really important thing to understand that in anything we do, especially these kinds of residential alternatives, has a great risk of failure. We've seen this over and over in our lives, those of us who have been doing this for decades and decades. And we really just have to try and put the best safeguards that we can so that the institutional and clinical markers that have been spoken about today don't infiltrate the model that we're talking about. And I would align that with the question that came from, I think had the name Peter Clutterbuck on it, and there was I think 3 ladies asked some questions, and one question was asked to Sherry about what does medical model mean? And for me, when I became to understand that, it really created the difference between what we want and markers of failure. So if I begin to see you as sick, ill, and diseased and treat you that way, then we will be failing our model. If I, regardless of your current medical condition and age, see you as a grandmother and a quilter and a bridge player, then I will know that we are on the right track, because it's how I see you implies how I treat you. So the question about the medical model that was asked earlier by that woman in the Toronto group, I think is a powerful question to keep alive in the debate that we have.
You're fading in and out, but that's a beautiful message that you're sharing with us.
Yeah.
Do I see you as a person with gifts and strengths and capacities and relationships?
Yeah, and just being able to understand that if we begin to see you as those roles
Thank you, Marilyn,
that
for
you had
reminding us
and have
how
those kinds
important
of
it's going to be
interests.
as this evolves. Yeah. Thanks, Marilyn, for reminding us right from the beginning, which is why you know that the discussion with Sherry about ongoing learning
Audio is off.
going to be very, very important as well.
John, you're having some problems with your connection.
Okay, I guess we all are. I think maybe it's a good time to wrap up. Let me just thank the team, Sherry, David, Doug, passion and commitment to helping this work. It's really been an honor to work today. Great questions, great comments. And we look forward to working with some of you in the weather session like this in January.
Hi, everyone. John, can I jump in here?
We really move things ahead anymore.
I think John's.
Thanks, everybody.
Unless it's just my computer. But I just wanted to also say to everybody, there was a comment about the intergenerational proposal being put forward in Ottawa by Village Canada. That is going to be a Zoom session on the 23rd of September. That'll be a Zoom session on the 23rd of September. So watch for that. The flyer is going out into your mailboxes tomorrow morning. John, I don't think we can hear you. Can you hear me? Can you try speaking? I just want to make sure you're okay.
It's John's connection. Everyone else is good.
Okay, all right. Then in that case, John, I will for you. Thank Sherry and Doug and David for an excellent presentation, and everyone who attended as well for some fabulous questions. We really appreciate all of you, and we know you're going to go back now and make your counselors' lives hell to get them to do this in your part of the woods. And any help that you would like from us, please do get in touch. I put our email address up there, seniorsactionontario@gmail.com. We're going to really try and get this going, and I think it's very nice to see Ontario Health taking this initiative, and they're very eager to get these things going. So thank you to everybody. You've done a wonderful job, and we really appreciate all of you. Especially you, Sherry, John, David, and Doug. Thank you.